testimony for the representative items of the court's rule. Okay. Cross-examination.
Ron, we would next call Richard Haymo to the stand.
Richard Cahill. Please raise your right hand. Do you swear or affirm all testimony you're about to give will be the truth so help you God? You may proceed. I know you've been here before. Would you please identify yourself again to the court?
Yes, my name is Richard Cahill.
And Richard, where do you live?
I live in Rivers, Kentucky.
Would you please refresh the court's memory? What do you do for a living?
I own 2 restaurants in the bakery, and they're located in Grant County and
And what's the name of your restaurant?
it's called Boone.
And your restaurant locations, are they open to the public for dining, sit-down dining?
Yes, they are.
The last time we were here, you testified about the precarious financial position of your restaurants. Is that still the case?
Yes, it is.
And does that have anything to do with the governor's capacity restrictions?
Yes, it is.
And why is that?
The limits on my capacity, there is a general overhead cost that is undertaken by us, that we have to have a certain amount of staffing. And so whether I have 10 people, 20 people, or if I'm at capacity in a restaurant, it takes a similar amount of labor. And therefore, I'm not able to be profitable at a reduced capacity.
Richard, do you have a COVID-19 operations plan in place?
Yes.
If you could please turn in a booklet to plaintiff's exhibit 3, could you identify that document for the court?
This is Bean's HB1 COVID-19.
And do you follow that plan to the best of your ability?
Yes.
Do you have a copy of that plan posted?
Yes.
To your knowledge, has there been any spread of COVID-19 at your business establishments, at your restaurants? Now, your plan, looking through it, references, quote, CDC guidance for your business or restaurants. Are you familiar with that CDC guidance?
Yes.
Could you please turn to plaintiff's exhibit 4? Go on. Could you identify that? To the best of your ability, do you follow that guidance?
Yes.
What is your understanding in that guidance of words such as consider, encourage, promote?
These are things that I do my best to implement in the circumstances and needs of my business.
And what is your understanding of words in that guidance such as require and ensure?
But there are things that must be done.
And based on your understanding of that guidance and the governor's mandates, is the CDC guidance less restrictive than the governor's mandates?
Yes.
Richard, if the capacity restrictions return to normal for your restaurant, would that make a difference to your financial prospects for staying in business?
Yes, it will.
And are you currently confident of your continued survival if that change, those restrictions aren't eliminated soon?
No.
Personally, how hard are you working to stay in business?
Personally, I can't work beyond my current capacity. I am working as hard as I can, as much as I can, for as long as I can.
Over the last year, have you had any interactions with the Northern Kentucky Health Department?
Yes, I have.
Have you received any citations for it?
Yes.
Could you please turn to plaintiff's exhibit 1 in that booklet? Could you identify that document?
Yes, I'm here. This is a citation that we received at the Bean's location in Hebron. But the Kentucky Health Department.
Generally, what are the circumstances of receiving a citation?
I believe that one person or more was not wearing a mask at the facility.
Did you have the opportunity to contest that citation in court or just some administrative body?
No.
And if you had an opportunity to contest it, what would you take advantage of that opportunity?
I would take advantage of it, and I would explain to them the health exemption requirement. There was a health exemption by the person that was not being asked.
Now, you testified about the governor's capacity restrictions. What percent of your seating capacity in your restaurants is reduced or eliminated pursuant to those restrictions?
I have, following the governor's restrictions, 2/3 of my seating is not in use.
Since you adopted your HB1 plan, has there been any, and you've been following that, have you been following that instead of the governor's mandates?
Yes.
In the past year, has there been any enforcement action against you regarding the governor's mandates not following?
Yes, there has. I was criminally charged by the sheriff's department.
How did that happen?
They came to my home, my children actually answered the door, and I was issued a subpoena.
Do you have a reasonable fear of further enforcement action against you?
Yes.
That's all we have, Your Honor.
Thank you, Mr. Ado. My name is Taylor Payne. I represent Governor Andy Beshear. I just have a few questions for you to follow up on some of this stuff. Exhibit 1 that Plaintiff's Counsel had you look at, that is a face covering citation. It appears here it was entered 9/29/2020. Does that sound right to you?
That's the date on there.
Okay. And was that around the same time that the sheriff's office came and served you a subpoena? Was it in regards to this citation?
It was not at this time. It was after that.
You know about how soon after that it was?
Yes, it was in December that the sheriff's department came up.
Okay. And so that occurred then prior to the passage of HB1, correct?
I'm not familiar with the exact date of the HB1, but it occurred prior to our implementation of our HB1 plan.
Right. And so do you know when you started implementing that plan?
I don't have the exact date.
That's okay. So you haven't faced enforcement action. I guess what I'm getting at is you haven't faced enforcement action since you've been following HB1.
That's right.
Thank you. And so when you would face enforcement action, that's because you weren't following the governor's guidelines, but there weren't other guidelines that you would pass by the legislature that you were following, correct?
The subpoena I believe that's correct.
Thank you. And I would like to touch then on the CDC guidance, which I believe is Plaintiff's Exhibit 4, if you still have that in front of you.
Yes.
And this is what you referenced and have stated that you're following in your HB1 plan that is Exhibit 3, is that correct? Was there any other guidance from the CDC that you used to create that plan?
The plan that we put in place was based on the CDC recommendations and legal counsel.
Right, but was it this, it was this document, Exhibit 4, that plaintiffs had attached, or I guess it could have been a prior versions. This looks like it was updated December 16th, 2020.
Again, it was based on the CDC recommendations at the time and legal counsel.
Okay. And do you know if it was a similar document to this, if it was for bars and restaurants?
I'm sure it must have been.
Okay. And if you don't mind, in that same exhibit, if you can turn to page, it should be towards the back here. I think it's going to be page 9 of that exhibit, 9 of 10. under other resources here, there's another, it's sort of bullet points. Do you see those on the document?
Yes.
And so here it says other resources, there's a cleaning and disinfection that is a link to other CDC guidance. Are you familiar with that guidance?
Am I familiar with that exact link?
The cleaning and disinfection guidance of the CDC.
Am I good? I'm not certain. I don't know which of these that I have looked at or not looked at.
Okay.
Does that answer your question?
Yeah, that is to the best of your ability. Thank you very much. There is also guidance for businesses and employers. Are you familiar with that guidance?
So we follow all of the guidance that we have the ability to follow and that we understand.
Okay. And so what if you don't have the ability to follow guidance? What sort of, do you take any other affirmative steps just on your own, or?
We follow it to the best of our ability.
Okay. Do you know if there's any part of the guidance that you're unable to follow?
No, I'm not familiar with that.
Okay. And you are familiar with HB1 to the extent of what it requires of your business, correct?
Again, I don't know what all is in that, but with the assistance of legal counsel, we developed that plan that is in here, and I follow that to the best of my ability.
Okay. Are you aware of any enforcement action that could be taken against you if you were unable to comply with HB1?
I don't know what could happen. I do know that I have been charged previously, and I'm concerned that could happen again, but I'm not doing what I'm supposed to do.
But just to clarify, you were charged prior to implementation of an HB1 plan because it was alleged that you were not following guidance or rules and regulations put in place by the state government, correct?
I don't believe I was charged for those reasons, but I know that I was charged at the request of the Northern Kentucky Health Department.
Okay, thank you. And under HB1, do you know if there was any enforcement action taken against you, that would provide an opportunity to contest that?
I'm sorry?
If you were found to be in violation of HB1, in terms of you weren't following applicable CDC guidance or something like that, do you know if HB1, does it provide you any sort of way to challenge that notification?
I'm not certain what it provides me or doesn't provide me. I just know that that this plan is put in place with the help of my counsel, and I follow it.
Okay. And how long have you been following HB1?
For as long as I've had the document.
Okay. Do you have an estimate of how long that would be, or a guess?
I don't have a date on it, but I believe a couple months.
Okay. And again, what happened with the charges back in 2020?
Somebody showed up and home and charged.
And ultimately, were those what happened with the charges in court?
They were dismissed.
Okay. Just 1 second. I don't know. Okay.
That's all we have, Your Honor. Thank you.
I should have asked, does the attorney general have any questions for this witness?
No, Your Honor.
Yes, I have.
Your Honor, I think my next witness is in the hallway. Sure.
Council, please put his name.
Dr. Molly Rutherford, Your Honor?
False Dr. Molly Rose. For being seated, please raise your right hand. Will you swear or affirm the testimony you're about to give is your true self? Thank you. You don't see it. You may proceed.
There's an exhibit in front of you. You turn back to page 50, or this is number tab 15. Can you state your name for the record?
Mary Rutherford, I go by Molly.
Okay. And let's just start with your background. You have an undergraduate degree?
Yes.
From where?
Virginia Tech,
And in what?
biology.
Okay. You have a master's degree?
Yes.
From where?
Johns Hopkins University.
And when did you get that?
I graduated in 1999.
And what was that degree in?
Public health, master's in public health with a focus on epidemiology.
Okay. And did you have any internship or a thesis connected with that?
No, it was a part-time program that I was taking while I was working at the National Institutes of Allergy and Infectious Diseases.
Okay. When were you working at the National Institute of Allergy and Infectious Diseases?
I worked for that institute from 93 to 99 as a biologist first, in 2 different labs, and then as a policy analyst with the office of the director,
Okay. And who was the director at that point in time?
Dr. Fauci.
So you worked for Dr. Fauci for how many years?
Down the hall from him for 3 years.
Okay. And what kinds of things were you doing in connection with that work?
We prepared him for briefings on Capitol Hill. I wrote his remarks to the NIAID Council, which met quarterly. I had some other responsibilities, but for him directly, it was mostly briefing him for various appearances that he might have.
Okay. What did you do after your master's degree and your time working for the National Institute of Health?
I started medical school in the fall of '99 at Eastern Virginia Medical School.
Did you graduate medical school?
Yes,
Are you a medical doctor in the Commonwealth of Kentucky?
yes.
Where else are you a medical doctor licensed?
I'm licensed in Indiana as well.
Have you done any publications as a medical doctor?
I've written some, one publication that I did recently was on the treatment of COVID. And other publications have been as the president of the Kentucky Academy of Family Physicians.
What is the Kentucky Academy of Family Physicians?
It's the state chapter of the American Academy of Family Physicians. So it's a professional organization, basically.
Okay, and I take it covers the family doctors in the state?
Yes, most family physicians belong, but not all of them.
Are you the current chair of the board of that organization in Kentucky?
I'm no longer the chair of the board, I'm on the board.
But you were the chair of the board and the past president?
Last year, yes.
Let me ask, Your Honor, at this point, I would proffer Dr. Rutherford as an expert in medicine and public health.
I don't object to her approach to the general idea, but we still don't understand for what purposes is being offered, so I may have relevance concerns with this testimony. If this is about the efficacy of different interventions for COVID, or whether the mask mandates were applicable or good policy, we're here to talk about the laws and whether or not they're constitutional and enforced. I'm not sure what this witness is offering toward the questions we're here for today.
Your Honor, the governor has filed a briefing in this matter that indicates that public interest and other factors weigh against the issuance of a permanent injunction. And to deal with that, and I don't think this kind of testimony has been offered in any of these cases today. We have a couple of experts that are going to establish that the sky isn't going to fall if the law is followed in this case. And people aren't going to die if the law is followed. And I think we're entitled to put on that evidence to meet that injunction issue.
I think this goes back to the discussion we had at the beginning of whether or not injunctive relief is appropriate in light of Beshear versus Avery and the Supreme Court and then statement since of the Court of Appeals in enjoining and staying the spot service injunction. On top of that, we also, we admit we're in a evolving situation, and the governor has even announced a lifting of all restrictions by June 11th. So I do question the relevance of this in light of the posture of this case, where we're talking about declaratory relief and possible injunctive relief, that we do contend that injunctive relief is inappropriate. Particularly, the Maupin factors are not appropriate.
Okay, well, I guess, you have something further?
Yeah, Your Honor, I think it's one thing for the Court of Appeals or the Supreme Court to stay on Scott Circuit Court, where there's been no evidence that, or where the governor has gone and cited a bunch of studies and emergency motions about, the sky falling, for lack of a better term, if his mandates aren't carried out. And I think we're entitled to present medical testimony that is bunk science and that it is lacks a foundation. And I think we're entitled to go to record, Your Honor, to defend a permanent injunction in this case. And that's really what this is about.
As I see it, that's something that really wasn't cross-examined at the first hearing. For the most part, I think plaintiffs and Attorney General acquiesced to the declaration that there was a pandemic and that there was need for responsive measures, but I don't believe that what has been referred to as the science has ever really been challenged or cross-examined. Independent of whether or not the law of the case would preclude injunctive relief, I think it would still have a bearing on declaratory relief, so I'm going to overrule the objection.
Thank you, Your Honor.
Your Honor, I have I guess a pending oral motion to proffer Dr. Rutherford as an expert in public health and medicine.
Now, I think there was a fair concern before about what the purpose was. Now that there is that purpose established, do you have any objections to this witness as an expert?
I do, Your Honor. Her public health experience ended back in 1999. The experience since that time was as a family physician. While that is an obviously honorable and noble profession, I would say the public health information that this witness can proffer is dated and not as an expert.
Your Honor, she has training, education, and experience. She meets the 702 factors. Furthermore, I think if we need a couple more questions of her, that's fine. But I mean, family physicians literally are on the front lines every single day. I think we're going to maybe give them happy to ask her some follow-up. She's treated COVID patients. She's seen this firsthand in her practice. She's seen the effects of this disease in the intervention. She's read studies. I think she's fully qualified to testify on it. To the extent that they want to, get into her, to argue dated or whatnot. I don't even know that if somebody's an expert, there's an expert. I'm not aware that there's a shelf life on someone being an expert. I'm not aware of any case law that would support the shelf life theory of an expert, but I think clearly she's met the criteria. To the extent that they want to cross her on the timing, I guess they could for weight purposes, but I think we've met the threshold under 72.
Well, I guess there are other specific criteria that the court would need to entertain further questions that you would want to hear from this proposed expert under 702 or Dalbert or.
I do believe that given that she's being offered for epidemiology and is expected to testify as to something that I don't believe is in dispute at all related to the legal issues here, which is whether or not the bills that were passed by the General Assembly are in effect or not. That's really not particularly relevant. But to the extent we're talking about current epidemiology, I would expect to hear more information about continuing education, any seminar studies that have been done related to that in the 20-plus years since the offered witness stopped working on a day-to-day basis in public health.
Okay. Before I rule on your proffer as an expert, I would like you to ask some more questions concerning the witnesses, whether it's experience or other issues that would go to the objections made by counsel.
Okay.
You may.
I'm happy. Dr. Rutherford, you have been in the active practice of medicine since you obtained your medical license in 2003, not?
Yes.
And has that been a family practice?
Yes, family medicine, and I'm board certified in addiction medicine as well.
And what kinds of things do you do in your family medicine practice?
Treat patients from newborns to geriatric age for urgent problems, chronic medical conditions. I practice preventive medicine as well. I have been active in public health. I was a member of the Healthy Oakland County Coalition, and I helped them get the drug-free communities grant in Oakland County a few years ago. So I haven't been completely inactive in public health, and it's an interest of mine, so I do follow it.
Does your medical practice require you to look at emerging public health issues?
Yes, absolutely.
And so do you do that almost on a routine basis as part of your practice of medicine?
Yes, I have to stay current on the trends of infectious diseases and other illnesses that I treat.
Are those items discussed at times in connection with your work with the Kentucky Academy of Family Physicians?
Yes,
And so it probably wouldn't be shocking for medical doctors to have to understand emerging medical trends and health issues to be able to treat their patients. Is that fair?
I think it's helpful to have that background for sure.
And that's something that you do.
Yes,
Do you keep up with emerging literature on public health issues?
yes, I do, especially those that are interesting to me, for example, addiction and infectious disease also.
Doctor, have you actually had to treat COVID-19 patients throughout this pandemic?
Yes, we started seeing patients in the office in September primarily. Prior to that, we didn't see very many.
And how many have you treated?
At my practice, I have treated maybe 100, and then I've also done some telemedicine work, helping people who aren't able to see their doctors.
Can you turn to Exhibit 16 for me? Doctor, do you identify the document that's at Exhibit 16?
Yes,
And what is it?
it's a peer-reviewed article submitted back in December and accepted, and I'm one of the authors.
So you're a co-author. Is this an international article? Because I see that there's people from Germany and other co-authors on this.
Yes,
And this is dealing with the treatment of COVID,
yes,
multi-drug treatment of early ambulatory high-risk SARS-CoV-2 infection.
correct.
And so you've been involved in the publication of literature dealing with the SARS-CoV-2 infection.
Yes,
Your Honor, I renew my proffer.
And I will continue my objection. The only public health information you heard was about drug addiction and treatment, which is not an issue here. We're also not here to talk about the efficacy of different treatments for COVID, which I do believe this witness could testify as to. We're here to talk about, as I stated, these structural issues of these bills that are up. And it does not appear that this witness can offer any specialized testimony that would be relevant to the issues that we report today.
I'm willing to accept the witness as an expert. I find her experience, training, education, at least involvement in treating COVID-19 to be sufficient to pass on the questions that are here as to the, the nature of pandemic and the urgency and the measures taken. I think that, as was stated repeatedly throughout this case, that it's evolving, and I know that one expert is necessarily going to be superior than another expert, and given her unique qualifications and experience, and with regard to who she's worked for, I'm going to allow that.
Thank you.
Doctor, before I get into the specific opinions that you may have related to this case, and specifically some of the governor's mandates, and the necessity of them, let me just begin, you do have certain opinions concerning those topics, correct?
Yes.
And before we get into them, I want to talk about some of the bases that underlie and that you're relying on. If you could turn to Exhibit 17 with me. Do you recognize this research paper?
Yes.
Is it peer reviewed? What is this particular research paper?
It's an analysis of the methods various governments took to try to address the pandemic.
And did you rely on this, before we get to your opinions, did you rely on this study in rendering your opinions?
It was one of the subjects that helped me with my opinions, but most of my opinions have been formed through my personal experience as a family doctor.
Okay. I'd like to get, if you could, go back to page 5 of that, of the study. Right above the bullet point 4 of the discussion, there's a sentence that begins with lastly. Can you read that?
Repeat that?
Yeah, if you go back to page 5 on this study,
Okay.
and if you see there's a bold number 4 under discussion.
Yes.
And there's a sentence that begins with lastly. Do you see that? It's a sentence right above the number 4 discussion on page 5.
Oh, yes. Mhm.
Can you read that?
Lastly, government actions such as border closures, full lockdowns, and a high rate of COVID-19 testing were not associated with statistically significant reductions in the number of critical cases or overall mortality.
And do you agree with that?
Yes, I do.
Can you look at Exhibit 18? Let me just back up, Dr. On Exhibit 17, do you believe that the study in question is reliable?
I do.
Let's look at Exhibit 18. What's the title of this study?
Effect of school closures on mortality from coronavirus disease, 2019, old and new predictions.
Your Honor, just, obviously some of this can be in pause, but we're not here to talk about school closures. I'm not sure what relevance of an article about school closures has.
Yes, Your Honor. This particular study actually analyzes the fact that, in part, compares not simply school closures, but general interventions as well in terms of government capacity restrictions. Some of the things that were challenging in this case. And if we look at it, there's some conclusions that the study draws in part that these measures actually do kind of flatten the curve, but they actually increase the death rate, and that's going to be one of the opinions the doctor is going to render. And this study, she's entitled to rely on in part to render an ultimate conclusion. She's going to testify.
At basis of this case is the issue of the urgency of the emergency that was declared. That's not been presented or challenged or cross-examined, not at least to this court, so I do want to hear your vote.
Dr. Exhibit 18, do you find that to be a reliable study?
Yes.
The study concludes that interventions may reduce cases in the short term, but it leads to more deaths overall, and the focus should have been on protecting over 70-year-olds. Do you agree with that finding?
I do, and not just over 70-year-olds, but anyone who is at high risk.
Okay. Did you rely on this study in part forming the opinions that you've rendered in this matter?
It's one of the studies that helped contribute to my opinions, yes.
Okay. Let's look quickly at Exhibit 19. This is a recent, I think it's a JAMA, March 19, 2021, open letter, research letter. Do you see that?
Yes.
And this suggests ongoing immunity from both infections and vaccines. So the natural immunity and the vaccine immunity sort of being long-lasting and protecting against the variants. Do you agree with that?
From everything that we, the data that we have available now, yes.
And do you find this to be a reliable piece of research?
Yes.
Did you rely on it in part in rendering the opinions that you're going to render in this matter?
Yes.
Let's look at Exhibit 20. And I just want to get to the highlight. First of all, do you recognize this study?
Yes.
What's the title of it?
COVID-19 mortality, a matter of vulnerability among nations facing limited margins of adaptation.
Do you find this to be a reliable study?
Yes.
It's been received, accepted, and published, correct?
Yes.
Peer reviewed?
Yes.
It concludes in part that the stringency of the measures settled to fight the pandemic, including lockdowns, do not appear linked with the death rate. Do you agree with that finding?
Yes.
Dr. Exhibit 21.
Where were you reading from? When you were quoting?
Apologize.
Because I don't see that.
If you look at Results Council on the very first page, the last sentence. Exhibit 21 is a comment on the Flangsman et al. Article. You see that?
Yes.
What was the Flangsman et al. Article?
There was an article about the non-pharmaceutical interventions of European countries.
And so, do you know if it was used to support kind of the stringent public health interventions that governments relied on in enacting COVID-19 mandates?
Yes, it claimed that they did save lives.
And this article debunked those findings, is that fair?
Yes, that's correct.
Do you happen to agree with the article at Exhibit 21?
I agree that at this point, the non-pharmaceutical interventions imposed by all of these countries did not save COVID lives that are probably going to result in deaths from other problems.
Okay. And you found Exhibit 21 to be reliable, Bob? I want to look at Exhibit 22. Do you know what this is, and specifically the Table 10?
Yes,
What is it?
this was prior to COVID, these were the CDC guidelines regarding pandemic influenza.
And generally speaking, were they recommending 6-foot distancing measures or mask mandates?
No,
So that was the established science prior to the COVID-19 pandemic.
yes,
Do you have an opinion about whether or not that science should have carried forward into the COVID-19 pandemic?
early on when there was so much uncertainty, I was supportive of the recommendations of 6-foot distancing, the hand sanitizing, and I even got behind the mask mandates early on. But it became clear the longer that the more we know about COVID at this point, it became clear to me that they were arbitrary recommendations, and they were unprecedented, they were not based on what we had known prior regarding respiratory viruses, and that became more and more convinced that they didn't work.
Doctor, just quickly, Exhibit 23. This is the latest CDC guidance on safe activities between vaccinated and unvaccinated individuals. And this is a relatively recent guidance document, is it not?
Yes.
We're going to talk about vaccination and not vaccinated, but did you look at this in formulating your opinions?
This didn't help me inform my opinion, but this definitely leaves out 1/3 of the American population who have natural immunity.
Okay. And I do want to talk about that. I have one final exhibit that I want to look at, Doctor, and then we can get into the opinions that you've rendered. Exhibit 26, Council, it was a late addition, and it should be in your exhibit book. Your Honor, same for you, at the very back of the exhibit book, just up there. There's a chart comparing state populations, over 65 population, COVID cases. You see that? It should be at the back, it's very back of the
Yes.
exhibit book. Is this something that you looked at in formulating your opinions?
Yes.
And
Your Honor, we would object to this. There's no indication where this data is from and who compiled this.
Your Honor, I can get to it. I'm about to get to it.
As far as an exhibit goes, it's not being entered until that's.
That's right.
Established. So you can question based on this table, but otherwise it would be sustained right to last.
Doctor, were you involved in reviewing this particular table?
Yes.
And the population came from public sources, including the Census Bureau, is that fair?
Yes.
And that's where we got the population and the over 65 population?
Correct.
And I realize we could be looking at estimates at this point in time because, we just did the census and that data is not out yet, right?
Correct.
The COVID cases, did that come from the CDC?
Yes.
And the death rate, did that come from the CDC as well?
Yes.
Okay. And so there were some generalizations that got, that were derived from that, including the cases per 100,000 population, right?
Correct.
And the death rate per 100,000 and the death rate per 100,000 over 65, right?
Correct.
And we looked at states with strong interventions such as California, New York, Ohio, Michigan, and Kentucky, right?
Correct.
And we looked at states with no strong interventions that might have lifted the mandates, like Texas, Florida, Tennessee, South Dakota, and North Dakota, right?
Correct.
And Doctor, there was the totaling of the population of those states, that happened, right?
Yes.
And we looked at the total population of the over 65 population, right?
Yes.
We looked at the total COVID case reported, right?
Correct.
And the total deaths.
Correct.
And Doctor, as it turns out, the states that had the strong government interventions had an average death rate of 1,307.43 in terms of deaths per 100,000 over 65, right?
Yes.
Based on it's the average population of over 65. And when we looked at the states without the strong interventions, the death rate was actually lower. It was 1,091.
Correct.
What conclusions did you draw looking at this public information and the analysis that you did on it?
I concluded that the interventions did not have an impact on the death rate from COVID-19.
And so the governor's mandates of requiring restaurants to keep tables 6 feet apart, in terms of death rate, did it have any material effect on that?
No.
And that's one of the opinions you're rendering in this case.
Correct.
What about restrictions on hours of operation? Would that have any? Let me ask you, Doctor, is COVID able to tell time?
No.
So would restrictions on hours of operation have anything to do with keeping people alive?
No.
And I realize the governor has just announced that he's going to be lifting the mask mandate on June 11th, but in your experience, do you think the mask mandate at this point, based on emerging Science research has kept anyone, has been a factor in keeping people alive.
It doesn't look like it from the data now.
I'll leave it on cross, sorry.
Doctor, do you have any other opinions in this case that we've not already talked about?
My opinion since the beginning has been, I've always been worried, with my public health background, I've always been worried that we were not considering the secondary consequences of what we were doing. So very early on, this started to occur to me when one of my patient's sons was unable to have his court date for an offense, and he ended up overdosing, dying. And then his mother, who was my patient, was unable to tell her mother in person, and she was confined to a nursing home and was not able to have visitors. So that was the beginning of me questioning whether or not we were doing more harm with these mandates than we were preventing COVID deaths. And then two more of my previous patients died of overdose this past year. They were both in their 20s. I attended one of their funerals. And then another eye-opening experience for me was in May when my kids had not been to school since March 12th. They go to Boone County Public Schools. We're still not in school. And yet my husband, who works for Louisville Metro Police Department, was called to bring his riot gear to Louisville for a protest. And the way our leaders, federal and state, reacted to that woke me up to the reality that things might not actually be based on science.
Objection to the elements here. And in fact, if we're going to talk about the applicability of COVID restrictions to protests, Mr. Wiest is counsel in a case where he obtained an injunction saying they couldn't be on a political protest. So I'm not sure what that has to do with what we talked about.
Your Honor, we can withdraw that portion of the testimony. One second, Your Honor. Doctor, are the opinions that you rendered today rendered within a reasonable degree of medical and health certainty?
Yes.
Your Honor, I tender the witness.
Does the Attorney General have any questions to this?
No question.
Okay, that's your witness.
Thank you. Good morning, doctor. My name is Amy Covich, and I'm general counsel for the government. I'll be asking you some questions about your testimony. Good morning. First off, I wasn't clear in the presentation of the testimony. What are your opinions that you are rendering today?
My opinions are that the mandates that were imposed by our state and then many other states are causing more harm in other public health capacities and not saving people from COVID-19 hospitalization and death.
Are there any other opinions that you're rendering today? When you say mandates imposed by this state and any other states, I want to try to break down what you're saying so that I understand it. Are there any specific mandates you're taking?
Well,
You're taking exception to?
the closing of the schools is one that I'm particularly passionate about.
Are schools closed right now?
Now,
Are there any other mandates?
I think that the mandates on businesses, the restrictions of capacity have been harmful to many business owners. I have Many patients in my practice who are business owners, several of my patients work for restaurants, they lost their jobs.
So is it fair to say your objection to the capacity limits is an economic objection?
Economic objection in that it causes unemployment, which is known to cause death.
What is, but do you have an opinion with respect to the efficacy regarding health?
The efficacy of capacity restrictions.
Yes.
In my opinion, they're unlikely to be helpful.
What do you base that opinion on?
I base it on experience and data that is coming out recently. There's been data that, well, they've switched from, you need to stay 6 feet apart, and then they changed it to, okay, 3 feet apart is okay. And now there's new data suggesting that the virus is primarily spread airborne. So if you're inside an establishment, 6 feet is not necessarily going to be helpful if you're in there for a long time. So I take all those things into consideration, and I'm skeptical that it's helpful.
You presented several research papers that were presented as largely peer-reviewed one-on-one. Many of the papers you have in front of us today speak to that specific issue.
Of the capacity restrictions,
Yes.
not that I recall specifically, no.
You mentioned mandates imposed by our state and many other states. Did you do a comparison state by state of mandates of Kentucky versus other states and how they were similar or dissimilar?
I have done some of that, yes, comparing Kentucky to Indiana, for example, comparing California to Texas, California to Florida. I've looked at that data.
So the only specific comparison to Kentucky you are giving me is Indiana?
I've looked at Kentucky compared to New York, compared to Florida, compared to Texas, compared to many states, Tennessee, West Virginia, Ohio.
Did you generate any data related to that for our review today?
No.
Are you rendering any opinions about those specific differences?
Was that the results, the virus behaved the way it was going to behave regardless of what the government did?
Well, I will go then specifically, let's go to Exhibit 26, because I believe that will help us focus in a little bit on this issue. First of all, you mentioned that you reviewed this. Do you know who prepared this document?
The council, I assume.
Did you participate in the preparation of this document?
Actually making this document? No.
Did you review it for accuracy?
Yes.
Do you have citations for where each of the information in each column came from?
No.
Do you know how the states that were chosen to be included were chosen?
No.
You said you had compared Kentucky to California. Do you believe the restrictions imposed by Governor Beshear were comparable to those by Governor Newsom in California?
No, they weren't nearly as strict.
What about as compared to New York?
They were similar, but also not as strict.
What about as compared to Michigan?
Definitely not as strict.
If you discussed that the averages at the bottom showed that lockdown states had higher death rates than no lockdown states, is that correct?
I wouldn't say that's statistically significant, but it is a higher number, yes.
Okay, so but now you're telling me it's not statistically significant, is that right?
I mean, it probably is not. I didn't do the calculations.
And do you know who did the calculation?
We didn't calculate the statistical significance.
Well, I'm asking, do you know who did the calculation?
No.
And do you know who chose which states to put in lockdown and no lockdown states?
No.
And you testified that the Kentucky lockdown really wasn't comparable to, say, California or Michigan, is that right?
It's comparable, but not as strict.
And if you look at just the Kentucky line, even presuming this is accurate, which of course I don't have citations to where this information was pulled, where does Kentucky rank in deaths per 100,000 and deaths per 100,000 over 65?
It looks like in deaths per 100,000, Kentucky is last, and deaths are first, whichever way you want to look at it.
Would you say lowest? Would that be fair?
Lowest, yes. And, for 65 and over, second to lowest.
Do you draw anything significant from that?
It's good, but, not really, no.
Turning back to some of the articles that you discussed with Mr. Wiest. Turning to Exhibit 17, I believe that's the Chaudhry article. If I ask you, would the concept of there being level 1, level 2, and level 3 type medical proof, or is that something you're familiar with?
Yes.
Could you explain what that is?
The most rigorous type of data would involve a randomized controlled trial. Most of the epidemiological studies are the lowest level of evidence because it's based on observations and therefore correlations. So for example, if you take an epidemiological study and you're trying to prove that smoking causes cancer, for example, you can say that as a hypothesis from the observational study, but it's not considered a gold standard of evidence. So,
Can you get a facsimile of the gold standard by comparing, say, with the smoking example, some people who smoke versus people who don't smoke? Would that give you a higher level of confidence?
you mean having a control group? Yes.
Exhibit 17, what level of evidence is this type of article?
This is, exploratory analysis. So, case controlled studies would be better, but I don't really know, to be honest.
You look on page 5. We are talking about the different kinds of variables that the authors of this study noted. And table 3 in particular, we're talking about lockdowns, border closures, tests. Could you compare the types of so-called lockdowns, border closures, and tests to any of the borders in Kentucky? Oh, I'm sorry, Your Honor. It's Exhibit 17, and I'm on page 5. So can you say with any degree of certainty that what's presented in this paper is all applicable to the measures presented?
All of the measures worldwide were similar. I think that it's relevant.
did you compare the measures discussed in this paper to the measures that you take?
No.
Do you know if they are comparable to the current orders?
The current orders. No. Border closures and full lockdowns don't really apply for.
If you are looking at Exhibit 18, could you please turn to this page? What level of evidence is this in that group report we're discussing a few minutes ago? Level 1, 2, and 3, focusing anything that you guys.
This is more of a model, I would say, so it's very similar to the models that they developed early on to decide. The intervention. So it's definitely, would be considered lower.
And is this in fact analyzing one very specific model that was in use by the Imperial College of London?
Yes, that model, that was not accurate.
Well, under results on page 1, doesn't it say it would have produced a good forecast if initialized with a certain number, and that it predicted that school closures and isolation of younger people would increase the total number of deaths, although postponed, and suggest that prompt interventions were shown to be highly effective at reducing peak demand?
If the model had been more accurate, it would not. It's comparing the old predictions to the new predictions. So they're saying that if the original model had been more accurate, then we would have taken a different approach. That was what I took on it.
In the conclusion in the next column, this is analyzing the comparatively harsher lockdowns of March 2020. Is that a fair assessment?
Yes.
And this was published in September 2020, is that right? Or accepted for publication?
Yes.
Does that have particular relevance for the current state of our COVID restrictions?
To the current state of our restrictions, no. The restrictions have been adjusted recently.
Would you think that's a good thing? That it's good to reassess the data, especially with a novel disease, and I support it.
I do wish we had done that last year when we found out that children don't spread COVID, and that we could have safely opened schools full time.
But again, as we discussed, schools are not closed right now, is that correct?
They just opened in April, a year later.
You turn to exhibit 19. What level of, I hesitate to say validity, because all of the different types of things. What level of, how would you categorize a research level in the tier 1, 2, and 3?
It's just a discussion, basically. It's not not considered the highest level of evidence, but we have several news publications showing that neutralizing antibodies are effective after natural infection. There's an article published in Science November about that.
Is that presented here?
No.
It's at 21, which is the comment on response to a publication in Nature about non-pharmaceutical innovations in Florida. Where is this published?
I'm not sure if it's yet. May just be submitted as a manuscript.
How did you obtain this article?
This article is referenced on, I don't remember where this one came from. I believe it's referenced on, in another article about how lockdowns have not changed the course of the virus.
Turn to 22, and you were discussing the statements of the mitigation profile for influenza. In your opinion, does influenza behave exactly the same way as COVID?
It's transmitted very similarly. It seems to be more contagious.
So in light of that, would you expect there would be some difference in how the CDC and medical community would treat COVID versus influenza?
Yes, I think early on, the assumption was that COVID was going to be much more virulent, much more contagious, that it possibly could affect people of all age groups. And it turns out that they were wrong about that. We were wrong about that. And I do also think that some of the principles on the transmission of the virus turned out to be very similar to influenza, and we should have corrected our approach.
You mentioned paraphrasing incorrectly. Do you have any of that evidence in place?
That we were had scientifically knowledge.
About how it spreads, its virulence? In fact, if you go back to Exhibit 18, which was the analysis of the predictive model from the computer called Boone. You look at the conclusion on page 1 in column 2, doesn't it end with the optimal strategy for saving lives in a COVID-19 epidemic is different than that anticipated for an influenza epidemic with a different mortality age profile?
Correct, because COVID is more likely to affect people in long-term care. It's more likely to kill the elderly. So a broad brush approach is more likely to spread and kill people in dense areas. A broad brush approach, treating rural areas like urban areas, closing schools, is not a good idea. Whereas for maybe a severe flu pandemic, these interventions might actually make more sense.
So you do believe COVID-19 needed to be treated differently than influenza?
Yes, but we've never done lockdowns, school closures, anything for influenza.
We've never done school closures for influenza?
We close a school if there's an outbreak in a school for influenza. We don't close all schools. during influenza season.
And again, schools are not closed right now, is that correct?
I don't know that any schools in Kentucky are closed anymore, they just opened at the beginning of April, mid-April, I think, in Jefferson County.
That's one county? Do you have information about every county in Kentucky?
No, Oldham County opened full-time in April as well. Prior to that, we were on a hybrid schedule.
Do you remember giving an interview to WHAS 11 in April of 2020?
Yes.
Do you remember what about discussing Dr. Fauci and the CDC?
I do.
What was your opinion of the CDC and its advice regarding COVID-19 at that time?
In April of 2020?
Yes.
In April of 2020, I trusted Dr. Fauci, I trusted the CDC.
Do you recall stating there's a lot of uncertainty with this virus because it's new, so he's not going to say we know exactly what's going to happen if we don't know? But I trust he'll tell us straight to the American people.
I did trust that at that time, but I no longer do.
Has Kentucky in fact loosened its restrictions since April of 2020?
Yes, they opened the gyms June 1st, I remember that. Yes.
With regard to the schools, do you know whether or not the governor ordered the schools to be closed at any point?
He recommended that the schools be closed.
But you don't know if he closed the schools?
He did not ever, I was in close contact with Owen County School Board, so I know that he didn't say schools must be closed. He recommended.
Just for clear, there was a short period of time that the governor did order the schools to be closed. Yeah, between Thanksgiving and Christmas. As one measure was declined, and that never happened. And it was just related to the date. So in other words, those were made on a district basis for the most part, within that short period. Is that right?
Yes.
And redirect, ask those questions asked on Ross.
Not,
On page 2 of your CV, if you would please, sir, I see the heading Health and Safety Experience. Can you please, since we're here today to talk about restrictions imposed by the governor of the state of Kentucky on businesses operating here in Kentucky, primarily directed at COVID-19, to the extent you have experience, would be relevant to that sort of analysis. Please highlight that for the court.
Sure. Two of the areas are, I'm a certified industrial hygienist, meaning I'm exposure PPE and warnings expert. And I'm a certified safety professional, which is basically an OSHA expert. And so those credentials in part are gold standards, if you will, for testifying on exposure PPE and warnings.
Great. And do you have engineering experience as well?
Yes, I'm a professional engineer, and I have to register in the States. Both my company and myself are registered as professional engineers here in Kentucky, Iowa, Pennsylvania, West Virginia, Texas, and Florida.
Is your relevant engineering experience outlined beginning on page 4 of your CV? And then, sir, take you to the top of page 6. Is that where you've outlined your experience and your environmental experience?
Yes, I was, as I said before, I actually helped write the state of Ohio rules and risk assessment. I wrote I trained their risk assessors, so training them, and then I also helped write their online, validated all their models online.
Sir, turning to page 7, have you outlined in your CV all of your certifications, registrations, and honors for those professional assignations?
I believe so, yes.
Are you a member of any associations, professional or otherwise, pertaining to industrial hygiene or similar professions?
Yes, I'm a member of the American Industrial Hygiene Association, and I've also obviously been certified by the American Board of Industrial Hygiene. That's what's required to take. You have to take 3 exams, having certified.
Are your memberships in those groups outlined at the top of page 8 of your CV? Are you current, you hold any current patents?
I have 9 U.S. patents, mostly related to heating, ventilation, and air conditioning.
And you mentioned already that you authored a book, and turn your attention to page 9, please. Does this begin a list of publications in which you participated in general?
Yes.
Page 11, is that an outline of the presentations you provided that are in the field of industrial hygiene and related professional areas?
Some of them, not all. I've given three talks on mass to groups of 400 to 500 people in the last 6 months.
And lastly, would you turn to page 14, please? Is that a summary of classes you've taught at Franklin University?
It is.
Next, sir, I'd ask you to direct your attention to what's been marked for identification in the binder as Exhibit 13. Please turn to that, please. Tell the court what that is, please.
This is a list of cases where I've been disclosed as an expert witness, and in the third column, it'll be listed whether he's been deposed or whether he actually testified.
So, as you sit here now, sir, do you have any idea in your head how many times you've been tendered as an expert witness in a court hearing, and the court has approved or accepted you as an expert?
Well, I've certainly been disclosed in approximately, I think it's about 400 cases. I've probably been deposed perhaps was probably somewhere around 20 or so.
And in those cases, have you been accepted by the court as an expert witness?
No court has ever rejected my ability to testify.
All right. Have you,
At least where I've been thinking.
okay. Your Honor, based on this witness's testimony regarding his education, training, and experience, I'd ask the court to recognize under evidence rule 702 as an expert witness with industrial hygiene experience and allow him to express opinion testimony.
On industrial hygiene.
Yes.
None?
No objection to his quick qualifications in the field of industrial hygiene, depending on what opinions are offered. I might have objections to the relevance of those opinions, but I don't believe there are any objections to his qualifications as an expert in industrial hygiene.
Okay. He is accepted as an expert for that purpose.
Thank you, Your Honor. Sir, I'm now going to ask you to turn to what's been marked for identification as Exhibit 14.
I'm there.
Applying concepts of industrial hygiene, have you done an analysis of the exposure, personal protective equipment, and warnings? Those concepts of industrial hygiene as it applies to COVID-19 and the use of masks?
I have multiple times.
Is what's been marked as Exhibit 14 a presentation you prepared to address those issues?
For this court, yes.
You're the author of what's been marked as Exhibit 14?
I am.
If you would, please, start on slide 3.
All right.
And tell the court, again, I know you've covered it generally, but so I don't want to belabor the same issues over and over again. But if you would touch on your professional background, what's in slide 3?
Sure, I basically had 3 primary jobs. I'm old, so I've been around a long time now, over 40 years. I started as a research scientist at Intel. It's a big research house in Ohio, sort of headquartered, the largest research organization in the world, I think. But I started working at the Hanford labs in Richmond and Princeton, Washington. Eventually moved to corporate in Columbus. Was there about 10 years. You're a scientist, or all the way up to senior research scientist in Ohio. You can't be called an engineer unless you're a professional engineer. So once I had my professional engineering certificate, instead of being a senior or principal research scientist, I became a principal research engineer. There was a legal requirement that you couldn't be called an engineer without being a professional engineer. So by the time I finished at Intel, I was a senior research engineer. Mainly spent time in the lab, a lot of times with HVAC equipment. Then I moved over to Columbia Gas Research, where I continued as a senior research engineer and eventually managed the residential, commercial, power generation, and vehicle research and development. And I was on about 10 national committees as a consequence of that job. That's where I also got 9 patents. After about 20 years, I formed my own company, EES Group. It was headquartered out of Ohio. They are now, I think, the largest forensics engineering company in Ohio. When my son passed unexpectedly at age 21, there was no heirs, so I sold the company to the employees, intending to retire. I said earlier, I've been very good at it, but I still maintain a branch, if you will, of the organization for it.
Okay. And again, we covered your qualifications, but is that set forth on slide 4?
Yes, that's a summary. Yes.
Then slide 5, again, it's repetitive of your CV. Those are your professional organizations in which you maintain membership.
Correct.
So getting into the substance of your background and your opinions, can you tell the court what exactly is industrial hygiene is relevant for this hearing?
Yeah, this is very important because in every toxic odor case I've been involved in, we have at least 2 types of experts. We have the exposure PPE warnings expert,
That's somebody like myself. And then you have the medical experts, which are the causation. In other words, if exposure gets a certain level, a doctor will find that causes a sort of immunocerosis. So it's my job to determine exposure. And I've done that for years. And the difficulty is you have, in the COVID era, you have a lot of physicians opining on industrial hygiene. And I always say, your dentist may be really, really bright, but you don't want to do your heart surgery. So you have a lot of opinions from people who have medical backgrounds who may be perfectly fine and intelligent, but they do not have industrial hygiene backgrounds. They're not qualified to talk about those things. And if they were, you wouldn't need an exposure PPE industrial hygiene expert in all the toxic water cases. You just need a medical expert. And that's not the case. I've never been in a case. So the definition of industrial hygiene is spelled out here from the American Industrial Hygiene Association. It's the science and art devoted to the anticipation, recognition, evaluation, and control of environmental factors and stressors arising in from the workplace that may cause sickness, impaired health and well-being, discomfort of workers and members of the community. Well, what's that mean? That means our job is to anticipate and recognize and control things that hurt you. Everything from making them sick to killing them. And that's our job. So in the world, what we do outside of litigation as an industrial hygienist is you have this world of things that can make somebody feel bad. And you go in and you try to figure out which of those things are affected. And you write a report up, you test it, you do evaluations, you do interviews, and you determine as best as you can as an industrial hygienist what you think is impacting it. That information is given to a physician who, along with looking at the person themselves, makes a specific causation determination. But we take the world from very broad, narrow, and then the physician either agrees with and adds to what we do or doesn't agree. But our job, I'll give you one example that's a very good example. I was asked by an insurance company to go and sample for mold for a person who was claiming to have a lot of health effects. When I interviewed the person, all of their effects were gastrointestinal. Well, part of our training and experience is we have to know toxicology and epidemiology. And I knew that mold was associated with respiratory tract, nose to ear, and that gastrointestinal was more likely related to bacterial infections. Well, when I did the inspection of the home, there was a broken sewage line with basement species in the ground. I called the insurance folks and said, I want to sample for bacteria. No, we sent you out there to do mold. And I said, well, the symptoms aren't related to mold. And it was quite a discussion until I said, look, here's another equivalent. If your car is smoking like crazy, and you take it to the mechanic and he wants to look at the engine, you say, no, I want you to look at the tires. You know, you gotta let the expert do what their expertise is. Well, I did do this. When we did bacteria, I did bacteria sampling, and sure enough, they were all the charts. So I can't make I can't make the specific causation that bacteria are causing this person's illness. But I can say that when I did the analysis, bacterial levels were elevated and our symptoms were consistent with that. In a position to take that and make determinations as well.
So when it comes, sir, to stopping or limiting exposures in the field of industrial hygiene, what are the 4 key tenets?
Well, the tenets are that, first of all, you have to anticipate that something may be. In other words, part of our art and science is to recognize situations before they happen. And then, if they do happen, to recognize some cause and effect. And then the third part is to evaluate, okay, if there's an exposure, are the levels of concern, and if they are a concern, how do we stop or control? And that's where a lot of this mask issue, if you will, comes in, is a mask really controlling COVID? My answer is no.
So we'll get to that. Sir, turn to slide 7, please.
And then,
In the in the field of industrial hygiene, you mentioned that exposure is one of the concerns for industrial hygienists. Please explain to the court, how the industrial hygiene views exposure to personal protective equipment and moorings.
Yeah, I think the field of industrial hygiene is largely not understood by the public, including policymakers, media, et cetera. And so they often search out medical doctors for opinions on industrial hygiene. I'll just get everybody that industrial hygiene is not associated with dentistry. It sounds like an initial, but industrial hygiene is the evaluation of exposures and control.
And specifically as it pertains to exposure, what in general are the four primary pathways for COVID exposure to COVID?
Well, in general, there's four ways you can be exposed to a substance: inhalation into the lungs, breathing it in; thermal through the skin; ingestion, eating or drinking it; and intravenous, which is use, etc. For COVID, the primary pathway obviously is inhalation.
And then exposure is broken down. What are the two main parameters that affect exposure?
The two major parameters always on exposure are concentration. In other words, higher the concentration, Pericles, the more likely it is to cause health effects. Lower is obviously better. And then the second is time at concentration. Less time obviously is better. Distance can be an issue, but as I'll show, it's really, for COVID anyways, I don't think it's a primary factor.
So what can you tell the court regarding the use of PPE and/or mask as a measure of protection against the spread of COVID-19 versus the engineering controls of dilution and destruction?
What I'm about to, this is sort of a summary of what I'm to tell the court. First of all, personal protective equipment, PPE, is the least desirable way from an industrial hygiene standpoint to protect people. And masks aren't PPE, they don't even fall in.
Excuse me, interrupt you. Are you now on slide 10?
10, yes.
I should probably be on one.
The other point that I want to make to the court is that the scientific evidence is clear that most of the COVID-19 particles are what we call aerosols, not droplets. There's been a misinformation campaign talking about droplets, shine the light over here, when the issue is really aerosols, little guys, all the little guys. If in fact you believe that it's the little guys, and I think I can prove it to you all, then the 6 foot hole and mask basically are meaningless.
And by meaningless, you mean completely ineffective?
As close to ineffective as you can get. And the reason is that the little guys, the small aerosols, they'll get around the mask, as I'll show, but they can go through it as well. But the bigger important thing is that the bigger droplets either drop out right away, or, and I've testified before about this, but the little ones get past your nose and into the top of the lung much more easily than the droplets, where that mucus tissues tend to take away. The little ones are the ones that get deep into your lung and cause disease. And the other point I want to make to the court is that from an industrial hygiene standpoint, as I soon to show you, there are 100 times more effective methods to control COVID from an exposure standpoint than masks. In fact, masks doesn't affect it at all, in my opinion. The engineering controls of dilution and destruction should have been advocated right away. And you now begin, I've been saying this publicly in public meetings for about the last year. And you now see in the last 2 months CDC changing their language, and it's reflecting a lot of what I'll tell you today.
So let's move your testimony to the hierarchy of controls.
And this is a very basic premise in industrial hygiene. It's called hierarchy of controls. And that is, what can you do to stop exposures from most effective and least effective? And this has been around, close to 100 years. The first is, which is applicable to COVID, is substitution elimination. In other words, if you have a hazardous material or something that's being exposed to people, the best thing you can do is get rid of it or substitute it with something less hazardous. That will eliminate or really minimize the exposure. The next best thing you can do is what we call engineering controls. And that is you either dilute it, like with ventilation, you destroy it with technologies that are out there, or you contain it. Particularly in indoor environments, containment is not as much of an option, but certainly dilution and destruction are. The third most effective, or next to least effective method, is what we call administrative controls. And what that means is you basically limit the time somebody can be in an area where they're exposed to something bigger. Less time is better. And then you see this in radiation, where you can go in and work so long before you have to leave here. And the least effective method for protecting people is what we call personal protective equipment. For respiratory protection, that's the respirators, not masks. The key is that respirators have very distinct requirements for fit testing, medical clearance, etc. Masks do not. Masks aren't even on this list. And the reason that PPE is least on the list is because we know from decades of experience as industrial hygienists that it's not effective because it's uncomfortable and people won't wear it properly. And you can see that. I fly a lot and I watch, and how many people you see with the mask below their nose or hanging off the side. People, it's uncomfortable. They don't wear it. And we know that as industrial hygienists, so we try to do everything we can to avoid getting it.
So, if you would please, to slide 12. This slide addresses PPE and respirators, which your testimony is distinct from a mask, correct?
Correct. I'm illustrating here an N95. People probably heard about that probably 2 years ago. But they have now. This is an N95. They're sort of the bottom of the barrel of respirators, but they can be used, they can be sealed. And then you go to a hat-based respirator as the next one up. There's a picture of that on the right of page 12. The point to be made here again is that under OSHA, respirators have very distinct requirements. Masks don't, and masks aren't respirators. They can't be sealed.
Are you familiar with 29 CFR 1910.134?
Yes, I've testified on this hundreds of times.
And what does that federal regulation do?
This is the OSHA standard for under OSHA 29 CFR 1910.134 or 132 is the personal protective equipment standard. And then it calls out for respiratory protection, OSHA 29 CFR 1910.134. 134 is the respiratory protection standard, RPS. It has very distinct requirements for you to, like people like myself, fit testing for respirators, so we do this. And there are very distinct requirements in order to fit test and have someone wear a respirator. And I thought it would be informative to compare the major provisions of respiratory protection standard against a mask. And under a respirator, do you need a medical clearance to wear a respirator? Yes, you do, because some people can't. They have lung function issues. You can't put them in a respirator to affect their well-being. Are you able to wear facial hair if you wear a respirator? Absolutely not. It breaks the seal. How many people you see with facial hair that have masks? A lot. Do you require a fit test? Yes. How about a mask? No, you can't fit test it. I'll show that later. Do you require an annual requirement? Is there an annual requirement to fit test the respirator? Absolutely there is. How about a mask? No. How about change out? How often should you change out the cartridge of the mask? Under the respiratory protection standard, there's language that addresses that. Is there any change out criteria for these masks? How long can you wear them? How long should you wear them? Do they get contaminated? Do we know?
So, by the way, I think you jumped ahead to slide 15, am I right?
Yeah, no, that's what we were.
Not one there yet.
No, I apologize.
If you would, go back to in slide 14, you've addressed the distinction between masks and personal protective equipment. and what announcements the CDC has made.
Yeah, well, mine doesn't have it, so I was missing that section.
Oh, really? Okay, we'll jump ahead to 16.
Well, I think that's an important set, so I can tell you what they say.
Go ahead, go ahead and do that for me.
The, both OSHA and CDC have been at best dishonest. What OSHA will say is on page 1 of their guidance, they'll say, well, we recommend you wear a mask.
Excuse me, sir. Your Honor, since this is primarily for your benefit, I should make sure whether you do or do not have slides 13 and 14 in exhibit 14. Okay, you do have. Okay, do you have any objection to me going to the witness for this page? So, Your Honor, may I have first witness?
I guess we'll go back to 13.
Okay,
If that's okay with you.
yeah,
So what do OSHA say? They say on page 1 they recommend a mask, but then on page 6, I think most people probably don't, the public doesn't read through page 6
page 6 of what, sir?
of this guidance statement. You'll see at the bottom, every time I've used a reference, I give the URL. So if you want to go find that language, you can. Find it. What it says is surgical masks are not respirators and do not provide the same level of protection to workers as properly fitted respirators. Cloth face coverings are also not acceptable substitutes for respirators. So they're admitting masks are not respirators. CDC has similar language, and the URL is at the bottom.
Slide 14, sir.
Verse 14. And I'm pulling this directly from CDC. Under masks, do not provide the wearer with a reliable level of protection from inhaling smaller airborne particles. We'll talk about that. It's not considered respiratory protection. I think that's pretty black and white. It's a little disingenuous for them to say let's wear a mask. That's what I choose. Respirators filter out at least 95% of airborne particles, including large and small particles. An N95, for example, is called an N95 because it filters out 95% of the particles down to 0.3 microns. I appreciate the COVID's at 0.1 micron. Smaller than that. And then it says, as I said before, this isn't rocket science. Masks leak. There's multiple literatures that say that. I can tell you that's the case. I've actually done an example slide here to prove it. That's why you have to have a fit test or a piece of equipment that will fit test. Otherwise, everything just runs around the device you're trying to protect.
So, I think I interrupted you last, you were on slide 15 explaining the difference between the respiratory protection standards found in federal regulations for a respirator versus what can or may apply to a mask.
Right. OSHA does not have a standard for masks. They have a standard for respirators.
So on the first line there, you have medical clearance to wear. Do you need medical clearance to wear a respirator?
Absolutely.
How about a mask?
No.
And then the second line, can you have facial hair and effectively wear a respirator?
No.
And what about a mask?
No requirements one way or the other.
What about, is there an initial fit test to determine the efficacy of a respirator?
There is.
What about with a mask?
No.
How about an annual requirement to undergo a fit test with a respirator?
That is a requirement. In fact, I've cited numerous organizations in terms of my opinions in court cases where they didn't do it annually. So that is a requirement under OSHA for respirators. There is no such requirement for masks.
Does that apply to masks? You already said it. I'm
That
sorry.
does not.
How about the change-out criteria for filters and/or cartridges? Does that apply to respirators?
There is language addressing that under the respiratory protection standards.
Does that requirement apply to the use of masks?
There's no such language regarding masks because the respiratory protection standard doesn't deal with this, it deals with respirators. And there is no equivalent standard for masks.
How about training on the use of a mask or respirator? Is there a required training for use of a respirator?
There certainly is.
Does that apply to masks?
Not that I know.
What about training on storage of a mask or respirator? Is that required for use of a respirator?
Absolutely.
How about a mask? And is there any provision for auditing the effectiveness of the mask or respirator for respirators?
There is not. Not that I know.
Well, there is for respirators and not for masks.
Correct. Correct.
Are all of those steps that we just went through designed to make sure that the use of a respirator provides the maximum protection for the wearer?
It's designed to make sure that the respirator is effective, yes, for its intended use.
Based on that analysis of what is required for respirators but not for masks, does that lead to a conclusion as to whether or not masks meet key respiratory protection standards as promulgated by OSHA?
But they clearly do not.
Now, during your testimony moments ago, you mentioned the difference between droplets and aerosols. Has OSHA given guidance on those two, the difference between those two concepts?
Yes and no. There has been a campaign to suggest that masks stop droplets, which may or may not be the case depending on if they're sealed or not. But the key is the little guys. And masks, as they admit, do not stop the little guys. And as I'll show in detail from the literature, the little guys are what are important.
Are you, turn if you would please to slide 17. And would you please explain to the court what slide 17 outlines?
This is a recent paper from Edwards et al. That just came out of the National Academy of Sciences Press. I'm going to have to spend a minute to describe what's here because it is complicated, but then I've summarized it in the next slide. What you have here is because you're not allowed to intentionally affect people with potentially deadly diseases, the next best tests are on monkeys or primates. So what they did in this study is they looked at emissions of particles when they breathed, before they were potentially infected and then after they were infected. And they looked at the size of particles that were emitted. That's where this slide gets complicated because it's not only, so if you look at the blue lines, those are 0.3 micron particles. The red is 0.5. And it steps on down to D, which is 10 microns. The scale is a little bit misleading because it's logarithmic, so you go from 1 to 10 to 100 to 1,000 to 10,000. The key here is that the definitions of aerosols are particles that are less than 5 microns. And for droplets, they're 5 to 10 microns and greater.
So just because not everybody may be familiar with the abbreviation and the symbol for micron, could you explain to us what that looks like?
The micron is a mu. It's 1 millionth. It's a big letter mu.
On this slide 17, is it the backwards U before the M? Is that,
Yeah, I guess that's how you can describe it actually.
well, I didn't know how else to say.
Yeah, it's a Greek letter for mu.
Okay.
So it's a little hard to see that, so I thought it would be helpful to people that I present to as well as to the court to take that data and summarize it by totaling all the values that are aerosol sized and all the areas, all the particles that are droplet sized. And that's on the next slide 18. I don't know if you want me to move.
Yes, please, start with slide 18.
So-
Explain how you organize that data for the court.
Yes, so across the top we have days after infection. Well, -1 means that's before infection. And I've totaled all of the totals less than or equal to 5 microns, and then equal to 10 microns, and then looked at what percentage are the little guys, the small guys. And you can see that and then it's plotted down below. You can see before they're infected that they're emitting on the order of 11,000 particles. And of those, 99.9% are less, 5 microns or less, the little guys. After the primates the monkeys infected, the emissions begin to go up, not a surprise, and they almost double. But the point to be made is that the particles that are being emitted are over 99.9% are the little guys. 5 microns are smaller. They're not droplets. And that's seen on the plot where the orange at the bottom doesn't get off hardly to zero, whereas up above you can see that the blue curve is the micron-sized particles, and they're on the order of 10 to 20,000, whereas the 10 microns are like 1.5 to 9.
What conclusions were drawn from that study?
Yeah, these on page 19, these are straight from the paper. And I highlight the things that are important in red, at least to me. Majority, they say that the small respiratory droplets, i.e. aerosols, were the majority of particles held in all subjects, because there were multiple monkeys that were done. And I've shown that. I mean, it's 99.9%. It says there may be an elevated risk to SARS associated with the very small particles, and that they may transmit through conventional mass and transfer distances far in excess of 2 meters or 7 feet. So, and it says that the exhaled aerosol numbers appear not only to be an indicator of disease progression, but a marker of disease risk in non-infected individuals. So that says they're concluding that the disease risk is associated with the little guys. That isn't rocket science either, because I've been involved in multiple cases where it's the little guys that are of concern, whether it be asbestos, whether it be silica, whether it be benzoyl ammonium chloride. It's always that small fraction that we worry about.
So on multiple occasions now you've made reference to the little guys and aerosols and microns. Have you prepared an exhibit that would show the court exactly how small a micron is?
I have, because when you say microns to people, they don't really know what that means. So what this slide 20 is the black circle. Imagine that as a cross section of a human hair. And imagine the little red dot where I have the arrow pointed to it. That's a micron. And so in terms of area, a micron is 4,000 times smaller in area than a human hair, and it's about 90 times smaller in diameter. Appreciate the COVID is 1/10 of a micron ballpark. So that means that the COVID is 1/10 of this little red dot, which means that it's 40,000 times smaller than the cross-sectional area of a human hair, and about 1,000 times smaller in diameter. So then I ask the question you've seen people ask, do you believe that you could slip a human hair by somebody's mask? Because you always have that area by the nose that's open. And the audiences I go, of course. And I said, you think that little guy that's somewhere between 1,000 times smaller in diameter, or in diameter, and 40,000 times smaller in area can get through there? That's like a huge pane glass window with no window in it. It'll go right through there.
So, and does the size of the micron or the 1/10 of a micron of a COVID virus have anything to do with how long it will stay in airborne?
Yes, that's the other factor.
Can you take us to the slide in which you outline those relationships?
Yeah, this is 21. This is, it's both from engineering and from industrial hygiene science. I cite a reference there on how long does it take for a particle of different size and density to fall, or what's the velocity? And if you know the velocity, feet per minute or whatever meters per second, then you can calculate in still air how long it will take to fall. So I thought it would be interesting to figure out for different sized particles, how long would it take to fall 5 feet, which is kind of from people's nose to the ground. And this again is in still air, not in air that's mixed. Because if it's mixed air, it's going to resuspend stuff. So what I've got here is a plot of the particle size in microns. We've talked about that. And the ones that are shaded or covered in red are the little guys, less than 5 micron aerosols. And I then looked at the time to fall 5 feet in terms of hours and days. Now it is true if you get particles that are 100 microns, it only takes a little bit of time to fall. But those aren't very interesting because they fall right away and they're out of the picture. But what's fascinating is if you look at, you take the density of COVID and you look at the literature I said that they were around 0.12 to 0.09 microns. The time to fall 5 feet was 46 to 58 days. Now, even if you go to 5 microns, it's almost an hour. So if it's days, if it takes days to fall, how in the world does a 6-foot rule have any meaning? Just an occurrence. People have seen, perhaps you've seen dust particles with sunlight. Sometimes you've seen dancing around, and if you move through them, they dance some more. Those are on the order of 40 to 50 microns. So these things are like 50 to 500 times small. So you can imagine that if you're in aisle 4 one day, and somebody had been sick several days earlier, and the HVAC system wasn't very good, those suckers are still there. So a mask isn't really the way to go. The way to go is engineering controls. It's to loot them and destroy them. And that's the natural hygiene approach. But the problem with aerosols, as soon as you admit they're aerosols, the mask don't work and the 6-foot will not.
So talking about what does work and what doesn't work, is the position of the CDC on responsive measures to the COVID pandemic, has it changed over time?
It has, and I think everybody recognizes that. Remember when that COVID first came out, it was surfaces. Everybody's fucking everything down. And then they started talking about profits. Now you see in the last 6 weeks, they're starting to talk about aerosols. My friend says,
By the way, are you referring to slide 22 as well?
yes. But it's always been about the aerosols. I've been talking about this, I've been drafting presentations since March of 2020. I've always said it's the aerosols, folks.
And why are they so important from your perspective?
Multiple reasons. One, they stay suspended for a long time. 2, they're very small, so they go right around and through masks. And 3, they are the materials that get into the deep lung and most likely cause disease. And that's straight from the literature that I've already cited.
Are those important reasons set out on slide 22?
Yes. And I won't repeat myself there, but it's, again, the keys, why they're so important is they're very small, so they stay suspended for hours and days. And that's still air. Believe me, if you walk through that air, as you see in much larger particles, they get resuspended. They may never settle. And so they can actually accumulate. If you got a lot of sick people in space. That's why when you heard this advice from public health officials, stay indoors, don't go outside, don't go to the beach. I'm like, no. The worst place in the world to be is indoors for kids and human. You want people outdoors, particularly on the beach where salt aerosols and float and et cetera destroy viruses. And that's why if you're indoors where the biggest problems lie, you've got to go to engineering controls. You really do.
Are you familiar with the 6-foot rule as it was recommended by the CDC?
Yeah, I began in March of 2020. I said, where did this come from? where does this 6 foot come from? And I never could find an absolute source. And I don't think it exists to this day. There's references to a 1930s study from William Wells at Harvard looking at droplets. I don't know if you're on that slide yet, but
Slide 24.
where they looked at bits of spit, mucus, and spat and phlegm, big stuff. And it tended to land within 3 feet of where they were. Okay, I don't disagree with that, but how does that relate to COVID?
Does it have any application to something less than 5 microns?
No. So, then, there's another study. I've been studying this, because I've been a member of ASHRAE, American Society of Heating, Refrigeration, and Air Conditioning for 40 years. I've been very interested in the air quality on planes because I think there could be a lot done that isn't done. That's another story. But anyway, in 2003 on SARS, actually I saw a presentation given on this in February 2002 or 2020 in Orlando at the ASHRAE National Meeting, and it was about SARS. And the example given was that if there was an infected person that went from Beijing to Hong Kong on a plane for SARS, and they infected, I think, 15 or 16 other people. And if you were plus or minus 4 rows, you had a 50% chance of being infected. So this plane study said, well, if you're 6 feet away or so, it could be a problem. But how that gets related to indoor environments and to outdoor environments is beyond me, because the air circulation in planes is terrible. I mean, what we really need in planes is we need little return ducts under each seat. And then we could, they always say, I got on a plane, our systems remove 99.9% of the particles, and we have an air exchange rate of 3 minutes or so. Well, the problem is it's 99.9% of the big guys, not the little guys. Depends what cut you're talking about. It's very misleading. And then the other thing is, locally, when you look at fluid dynamics of the air circulation around seas, you've got these big eddies. And so it may be 3 minutes that a bunch of air is getting fed through this device in the back of the plane, but it's many, many, many minutes. And the air that you're breathing gets back to that filter and back. And even then, that filter may not be able to handle the 0.1 microns. So basically, I conclude that there is no basis. And others have concluded the same thing. The only basis is this single airplane study, which I heard a presentation on, as well as a 1930s study. So, and as I've indicated before, just based on Stokes' law alone, the 6 foot rule makes no sense from an industrial standpoint.
All right, so let me change the focus a little bit. Previously, you were talking about the size of the COVID virus itself, masks and leakage in a mask. Could you turn, if you would, please, to slide 26 and explain for the court's benefit what the graph is there and how leakage percentage affects the efficacy of the mask?
Yeah, there was a very recent study by Boone et al. I've cited at the bottom of the slide here. And they were looking at the effectiveness for various sized particles, including droplets as well as aerosols, for various materials. But they pointed out in their paper a key provision, which is almost all of these studies that claim masks work are based on where they put the mask, they perfectly seal it, put it in some sort of device, mannequin or whatever, or an engineering contraption that seals it. But what they pointed out was, what they did was, they knew, as the literature has said forever, that, or not ever, but a long time, that if you have any leakage, you defeat a respirator as well as a mask. So what they did is they put holes in the mask, and they looked at, say the mask had a 5% effectiveness and it was perfectly sealed. And I said, well, how does that effectiveness drop if we put 1% of the mask in a hole or 2%? And what this shows is that if you have, for the small guys, less than 2.5 microns, if you put 2% of the mass area is not sealed, the effectiveness drops by 80%, whatever you had, which is what it started with. And I thought, well, that's interesting. Why don't we just project when it has zero effectiveness? So I took their data and I extended it. And I said, because it looks pretty linear from 0.5% out. And I said, well, you get about 3%. And whatever effectiveness that 3% pH, whatever effectiveness that mass had, albeit low, it's now zero.
Turn to slide 27, please, and explain what's the thing.
I thought it would be good to experiment on myself to see what the leakage is of the mask. So I took my Spirit Airlines mask because I've been on multiple planes where I wear a half-face respirator and I've been told I won't be able to fly again unless I put a mask on. It's like, it's insanity. But the only way they'll let me fly is if I stuff a mask inside my respirator. So I took one of those masks and I said, okay, what's the area? And I measured it, and it was 165.3 centimeters. And then I measured, actually I had my wife measure the area on either side of my nose, under my eye, as well as you can see the other thing here, we get a little triangular space where it crinkles. That mask is actually pretty well. And I said, what are those areas? And I totaled up those areas. And the areas just on those 4 spaces alone was 15.46 centimeters. The leakage area for me on that mask was 9.35%.
Now, on the previous slide, you just told me that if the leakage area gets 3%, the effectiveness is 0.
Well, the effectiveness of it's already low effectiveness of a mask through the mask, but even that effectiveness goes to 0 to 3%. So I'm three times that.
So that, based on the way you're depicted wearing the mask on slide 27, that mask has what percentage effectiveness according to your calculation?
0.
Are you familiar, sir, with any studies based on surgeons who are primary, that we think of when we think of surgical masks? And that there's the effectiveness of masks in that application?
And the beginning in 2020, I started looking at I had literature already, but I looked at literature on the effectiveness of surgical masks against flu viruses. And almost unequivocally, they said they're not effective. We had the Boulgard study from Denmark. There was 6,000 people. It's the best double-blind epidemiology study of masks versus no masks because they had 3,000 people without masks, 3,000 people with masks. And so they looked at the infection rate with masks, without masks. And the results were equivocal statistically, meaning there was no difference. But I wanted to look at it not from the epidemiology standpoint, but simply looking at the effectiveness based on leakage, particle size, etc. But there has been since that time, from 2015 forward, there's a lot of literature looking at the effectiveness of, say, surgical masks and what their intent is. The surgical masks are always intended to be big droplets out of the surgeon's mouth. They're not intended to be infectious diseases from either the surgeon or from the patient affecting each other. And this is one of those studies that says that.
Is that set forth on 28, 29?
It does.
What about the technical community seeking guidance from the CDC regarding the implications of aerosols?
Yeah, there was an interesting letter written to the White House, Fauci, a whole bunch of people it's on slide 31, from a whole bunch of medical researchers, physicians, PhDs. Really, in many respects, commenting on, so my opinions aren't just my opinions, but it's fascinating that a letter written by a lot of experts says basically the same thing. And I thought it would be useful for the court to see that the letter, what they said in that letter, to confirm a lot of what I've been saying.
Are the authors of that letter listed out on exhibit 31.
They are.
Turn to slide 32, please. And explain to the court what you put there.
These are direct quotes from their letter. It says, for many months, it's been clear that the transmission through inhalation of small aerosol, remember the word aerosol is the key word, not droplets, aerosol, less than 5 microns, is an important and significant mode of SARS-CoV-2 virus transmission. The gravity of this problem was emphasized in an editorial in Nature magazine. Then they say, numerous studies have demonstrated that aerosols produced from breathing, talking, singing, etc., can remain in the air and viable for long periods of time and travel long distances within the room. I think I've proven that by simply running a simple Stokes law test that you've seen earlier that they can stay in the air for hours to days. They go on. Page 33, further. They say, gatherings in indoor spaces without adequate ventilation place participants in particularly high risk. Remember I said engineering controls. In October, the CDC recognized inhalation as a route of exposure that should be controlled to protect against COVID-19. But most CDC guidance and recommendations have not been updated or strengthened to address and limit inhalation exposures to small aerosol particles. I agree. What they say about aerosols? CDC continues to use the outdated and confusing term respiratory droplets to describe both larger propelled droplet sprays and smaller inhalable aerosol particles. And they say it also confuses matters with airborne transmission to indicate inhalation exposure exclusively at long distances and does not consider inhalation exposures to be the same aerosols at small distances. Again, I've talked about the fact that since they're small, they can stay suspended and they just basically eddy around. When they get to 6 feet, they don't say, whoops, I gotta stop. I mean, that's silly. Then they talk more about aerosols. The artificial distinction needs to be replaced with up-to-date terminology, that is, droplets versus aerosols, including inhalation of small aerosol particles. They say CDC guidance and recommendations do not include the control measures necessary for protecting the public and worker from inhalation exposure to SARS-CoV-2. And I write, aerosols, the kingpin word that renders mask and the 6-foot rule essentially meaningless. So, what's interesting, this was in February. I tried to stay current with the literature. CDC said on 3/23.
Before we move on, are you on slide 36 now? Good.
They're now, the language is creeping in because they know, they're smart. They know that, just like I showed you earlier where they say, well, we recommend a mask, but then they say they don't really work for the little guys. They know. So now they're starting, it's going to be embarrassing politically for them to admit they were wrong. But they're getting started. They're starting to change their language and what they're putting out there. They now talk about engineering controls and destruction. Surprise, surprise. And then they finally admit that particles 5 microns and smaller may not settle for hours or even days. Where have we heard that before? It's the little guys, folks. The latest study, 37, it hasn't, it's just, the preprints are just out, it's scheduled to print in June. It's from a gentleman, I'm sure I'll put his name, Ben Shelton. He's associated with Stanford University of Palo Alto. These are the 2 conclusions he reaches. The existing scientific evidence challenged the safety and efficacy of wearing face masks as a preventative intervention for COVID. The data suggests that both the medical and non-medical face masks are ineffective to block human-to-human transmission of viral and infectious diseases such as SARS-CoV-2 and COVID-19. And they support and this supports against the use of face masks. And the other thing that they talk about is all the negative effects. And I'll let the medical folks talk about that, but here's a list of all the negative things associated with wearing masks. This is the latest paper that I'm aware of.
Well, I don't want to gloss over that too quickly. Can you please specifically identify for the court the substantial adverse physiological and psychological effects of wearing face masks?
Yes, first is hypoxia. For instance, I had pneumonia 2 weeks ago and I had to put a face mask on, or a respirator.
Objection, Your Honor, he just testified he's not a medical expert and can't opine as to this. It's one thing to say he's relied on his article and read what it says, but to expand on it and give medical evidence is outside of the, what the experts will have.
He's not providing his medical evidence, Your Honor. As an industrial hygienist, adverse effects of personal protective equipment, masks, or other efforts at reducing risk are within the scope of his expertise. We should provide that to the court.
I might add to the judge that 40% of my CIH exam was toxicology.
Your Honor, the witness literally just testified he was not qualified to opine on this section of the paper.
I believe that is such a liberal success.
We can see that. So then, sir, as an industrial hygienist, and the hierarchy of controls that can be implemented, what would be effective methods for reducing potential concentrations in indoor spaces?
Yeah, the engineering, remember the hierarchy of controls. We had substitution and engineering controls second. And masks weren't even on the other people. Well, under engineering controls, ventilation, and I advise people of this right away. Increase the fresh air ventilation. In other words, if you have commercial buildings or industrial buildings, the energy codes have so tightened down the fresh air supplies, most of the air is recirculating. I said, override the controls and maximize fresh air space. It will dilute whatever contaminants are in there by that. I said, if you have access to windows, crack the windows, use a little bit of energy, whether it be for heating or cooling. And then meet outdoors if needed. So those were, on the ventilation side, that was advice that I gave, including advice to a school of autistic children in August of last year that opened, to my knowledge, with dilution and destruction technologies. There were 900 students, 300 teachers. I spoke to them before school opened. To my understanding, and there's a podcast out there where I spoke the second hour and the doctor spoke the first hour about how effective it's been. But they've not had, the only instance they've had is where people brought COVID from home. So the second area is destruction. And there are a number of technologies out there that can be used. One of them is this needle point ionization technology. New Calgon iWave is one of them. I've put them in both of my residences, both of my buildings. I've advised dozens of people to put them in. Supposedly they destroy about 94% of the COVID particles per pass. I've said to everyone, wouldn't it have been nice if for $400 anybody would want when we gave it to them instead of these silly masks, payments, and all the destruction we had for economy. There are real technologies that have been used and are being used that can really make a difference.
And then you have at the bottom that PPE is the least desirable, but it's important to call one about masks.
Which ones are you talking about?
I'm at the bottom of that page.
This is on the emotional side. Because I finished first in my class in business on behavioral marketing, in the roundup cases, I define and link over 30 reports on the effectiveness of the art of persuasion.
So, sir, I'm still on 39. Are you on 39?
Oh, okay. Well, I just said that PPE is the least desirable option, and masks are not PPE.
Okay, that's what I want.
Yeah. So we really should be doing engineering controls.
So with regard to masks, you have this slide, the art of persuasion, appearing on slide 40. Can you explain that to the judge, please?
Yeah, I was taught a long time ago, and it's true, much to my chagrin, that in the art of persuasion, the most effective way to persuade people is with emotional appeal. The next most effective way is, we use the word propaganda, but it's repeated message, and the least effective way is logic. When I heard that as a senior research scientist was going to school back in the day, I was not happy. But it turns out it's true. So the emotional appeal on mask is wear a mask to protect your fellow citizen, etc. It's a very powerful argument. It works. The propaganda for masks is, you hear it all the time, mask, wear a mask, wear a mask, wear a mask. Say it over and over again, people say something long enough, people will believe in masks. Logic, masks don't work, it's the least effective. Right? Logic is the least effective way to persuade people. So these tools are being used today, whether it be for masks or vaccines. And in order for us to be persuasive, we're going to have to be emotionally persuasive, like showing the size of a human hair versus the size of the COVID particle. Prove to people these cannot work. Because
Touching the relevance, we're not talking about, I guess I'm not sure what the relevance is to what we're discussing.
Talking about in the setting of trying to avoid human-to-human transmission of the COVID virus, what has been the current, or the most recent efforts by the state of persuasion to use masks, which are completely ineffective versus what should be done. He's drawing a distinction between the two.
I understand the distinction, but I guess your response to whether it's relevant to the issue specifies
It certainly goes to the issues that we're here today to address, Your Honor, and it's,
well, we do need to get moving along.
so if you'd like me to accelerate, Your Honor, I can do that.
Move along. We're looking for now.
I understand. Sir, jump ahead, if you would, please, to slide 42.
yes, so
Before I ask you that, you've expressed some opinions today, and it's important for them to be received by the court to answer this question. Are the opinions you've expressed here today regarding masks, the 6-foot rule, personal protective equipment, and the industrial hygiene issues you've addressed, are they based on your education, your training, and experience, and are they expressed to a reasonable degree of industrial hygiene and certainty?
yes.
Go ahead. Now, with that in mind, if you please address, I think slide 42 is a summary of your opinions that you expressed here today,
Well, 41 is,
where it starts.
the key is the reason that I'm qualified by many courts to talk about the art of persuasion. The reason it's important is because we have to get the message out that engineering controls are the way to protect people. And the real message should be dilution destruction, not masks. And that's why that's important. Now, to close, I'll just say personal protective equipment is the least desirable way to protect people. Masks aren't PPE. Scientific evidence is clear that the particles are mostly small aerosols, not droplets. And if so, you would have respirators, not masks, to protect against those. And it would really render the 6-foot rule meaningless. The smaller particles are of most interest because they have the ability to get deep into the lungs where they cause disease. And the key is to replace this mask mantra with engineering controls.
When you were giving that last answer, I was informed by my co-counsel that the one thing I need to follow up with you on is this. Could you explain to the court what Stokes' law is?
Yeah, Stokes' law is a engineering equation as well as an industrial hygiene equation, so it's an engineering field. And what it does is it says for a given particle size and a given diameter density, how fast will it fall if it's allowed to fall in the still air. So you can calculate a velocity per minute. So what I did is I calculated the velocity for each of these different sized particles and said, okay, how long would it take to fall at that velocity for 5 feet?
Thank you. Your Honor, no further questions.
Council, break first, proceed.
I would love it if we could take a break. I don't know if you're intending a lunch break or just a small short break.
Let's, okay, the council, say, half-hour break for lunch,
That would be wonderful.
does that work for council? And then I should ask, does the attorney general wish to process, or ask direct questions? Okay. So then we'll break, come back here at 1:30. Right after 12:30. Back at 1:30. Unfortunately,